Niklaus Lang is known throughout the world of implant dentistry. He is a past president of the IDI and the Swiss Society for Periodontology. Professor Lang is active in clinical research related to implant dentistry, periodontology, etiology and pathogenesis of peri-implant infections, risk evaluation, wound healing, and oral microbiology. Please welcome Professor Niklaus Lang.
Good afternoon, dear friends. It is my privilege to talk about the patient risk factors for peri-implantitis. I would like to pick up on what Nikos Donos just said. Prevention is the best treatment. And I would like to expand that a little bit and say prevention is actually control of risk factors. So we need to know the risk factors, and Professor Mateos, in his first lecture, in his first slide, has pointed out the importance of the biofilm. Biofilms are with us in different parts of the world, in different fields, and it is clear that biofilms form an all-hard, non-shedding surfaces in a fluid system. And that is exactly the basics for an implant to collect also biofilm. And there are sometimes from industry propagations that our implant has a surface that doesn't form biofilm. This is not true. They are colonizing every hard non-shedding surface in the fluid system. Here is after 3 hours a few colonies, and after 3 days it's like that. And then in the microscope you can see it like that. So quite clear, this is our enemy number one, and if there were no biofilm, there would not be a risk for peri-implantitis. So it brings me to the etiology. And the etiology, basically, I would like to point out a few things on the mucositis, because we have the definite proof today that mucositis is a host response to the biofilm accumulation. And that response comes from a study in Bern. I'm very proud to be part of this. And it is entitled Reversibility of Experimental Peri-Implant Mucositis Compared with Experimental Gingivitis. Everybody in this audience knows what that is. The paper by Harald Löh in 1965, who established once and forever the cause and effect relationship between the bacterial plaque accumulation and the host response. So we have done exactly the same 20 years later or 30 years later for the implant situation. Here you have on the x-axis the time frame, weeks 1, 2, 3, without any oral hygiene, and you see how the gingival index moves upwards, and then that this is exactly the same for the implant situation. And this is within the same mouth, in the same patient. So we have established a cause and effect relationship between biofilm and host response. And this is basically the base for our therapy. And it's also to identify this as a major risk factor. How about when we leave time for it go and accumulate the plaque without affecting it at all? Well, this will inevitably, in most cases, lead to lesions that we then call peri-implantitis. And these peri-implantitis lesions, bear with me, we cannot test out experimentally in humans, so we normally go to the animals. And already 20 years ago, or 30 years ago, we have published a similar study on ligature-induced peri-implant infections that will, in the monkey, show you that we predictably can create a lesion, a peri-implantitis, just by putting a ligatures that collects biofilm. Here you have a ligated and a non-ligated implant and a ligated tooth in a monkey. And when we look at the development of the plaque index, of course it goes up, and then the result is the host responder gingival index or mucosal index. And you can see that the blue line, which is a non-ligated implant, has the least amount of pathology, while the two others, the red line and the green line, which are the ligated elements, tooth and implants, they do not differ from each other in the development of the lesion. And when we measure the lesion to a reference, we can see that in the course of 8 months we lose about 4 millimeters of bone. That's pretty much in a situation where the implant is 6 millimeters. And again, the non-ligated element has much less. So here is the demonstration also that the biofilm is the important thing. We can, of course, visualize that with identical radiographs, and those are identical radiographs. We subtract the following follow-up implant from the first, and you can see in these frames a blue stained field, which is bone resorption, and it's the same around the tooth as it is around the implant. We can also document that by cultivating the bacteria. Here is just dark field microscopy. You see there is an emergence of spirochetes in the ligated teeth and motile rods, and the rest is relatively harmless coccoid microbes. Now, the same is exactly true for the implants. So we must accept from a clinical point of view that these two diseases develop pretty much the same way. But we're also interested in the pathogens, and the pathogens here are the black pigmenting bacteroides, the gram-negative anaerobes, and you can see that the red and the green bar again are increasing about to the same extent, while the non-ligated implant is kind of a control with very low amounts of these gram-negative anaerobes. So this brings me to the third aspect of the etiology, and that is a typically patient-related centered outcome. The history of periodontitis. This has been said in previous talks, and I'm only going to give you one piece of evidence. It was the first one that we published already 40 years ago with a Greek guest in Bern, and Carusis went through the trouble of looking at our implant patients in a prospective manner over 10 years. And in this patient population, we had patients who had lost their teeth due to periodontitis or due to other reasons, agenesis, trauma, or endodontic reasons. And when you look at the survival rate of these two groups, there is a difference. And the difference even becomes significant after 7 years. While those who have lost their teeth due to periodontitis are down to about 90% survival after 7 years, the others are at 98 or 97%. The same applies to the incidence of peri-implantitis, which is of course the reason why we lost the implants. Now, this, if I mark here the various lines in green again, those who lost their teeth due to other reasons, there is a significant difference, especially when we look at the incidence of peri-implantitis. That is very little in those who lost their teeth due to other reasons, while the periodontally diseased patients, previously periodontally diseased patients who were all treated, had 28.6% peri-implantitis after 7 years already. Now, this brings me to the risk indicators or risk factors. You see, we have to go to the etiology to determine the risk factors. And we have seen that the biofilm formation and removal plays a big role, a major role probably. And we have a study there from South America, from Costa's group, that is very likely to demonstrate to us that if we leave unattended a situation, that we may increase the incidence of peri-implantitis. In this study, there are 80 patients, edentulous patients, treated for periodontitis first, and then 39 patients who were put in a preventive program, and 41 that were deprived of a preventive maintenance program. So you have a very nice material. All implants that were placed there were all diagnosed with a peri-implant mucositis. And 5 years later, they, if you look, if the preventive maintenance program was instituted, after 5 years they have an incidence of peri-implantitis of 18%. And the peri-implant healthy conditions was at 30%, so not 100%. But then if you compare that to those who had no preventive measures, the figures are much higher and significantly higher. Instead of 18, 43.9%. Instead of 30, 0%. Now, the next thing, of course, everybody wants to know is how about genetics? And for a while, this was a real hype around the turn of the century. And of course, it triggered everybody's interest to look at the polymorphisms, interleukin-1 polymorphisms, and smoking frequency on recall as a risk factor. Now, the patients we have incorporated in this study were stratified according to their smoking experience. You see there is small groups, but they are all about equal to look at. And especially we had non-smokers, 39, and we have heavy smokers, 14. These are the two extremes. But we relate these now to the interleukin-1 polymorphisms. If they were negative or positive patients, there is no difference in their alveolar bone loss. So normally it doesn't matter at all. But then if you look at the genotype negative patients, those who have a negative genotype, they show no difference as well. As you can see, former smokers, non-smokers, and heavy smokers have no difference in alveolar bone loss. While if I combine those, all of a sudden the smoker, the heavy smoker, has a significantly higher annual bone loss than all the others. And this shows you there is a genetic combination there if you have a genotype positive and are a heavy smoker. So only if the heavy smoking comes together with an interleukin genotype positive status is the bone loss more pronounced. The risk ratio is 2 to 2.5. This is much less than the biofilm accumulation. But let's face it, do we then do genetic tests? Does it pay off to pay 200 francs or whatever valuta you have for a genetic test? You cannot change it anyhow. So it is just one risk factor in evaluating your recall frequency. And I think we shouldn't make out too much of this. But the risk factor of smoking is, of course, an environmental factor, and that depends on how much you smoke. The literature is very clear about that. A non or never smoker has a much less risk for developing peri-implantitis than does a heavy smoker. I always take the two extremes. And this together was also put together in a recent systematic review and meta-analysis of 7 studies. At least 702 patients were incorporated in this, and over 3,100 files. And you can see the conclusion is that moderate certainty evidence suggests that smoking is associated with peri-implantitis compared to non-smoking at the patient and the implant levels. So this brought us to a realistic appreciation of the risk factors we know and we have evidence in the literature. And this is the so-called implant dentistry risk assessment, IDRA, that has shortly been presented by Professor Donos just a minute ago. It is our chairman there, or chairwoman, no, I think chairperson. I hope you are one of the 3. Lisa, who at a visit in Bern, Switzerland, we had to go and think about that because we had experience from the periodontal risk assessment. So we have presented this in a way that you have factors that are starting with the history of periodontitis, the local bleeding on probing percentage, the number of residual pockets greater than 5 millimeters, the bone loss in relation to age. These are all periodontal parameters. Then comes the periosusceptibility, there comes the SPT, or how well they adhere to the supporting periodontology system, and two prosthetic parameters. And like that you can go home on Monday morning and evaluate your implant patients for the risk for peri-implantitis. This has been validated in 3 studies very recently, and these studies are mentioned here. And the last one is a Chinese one, long-term clinical outcomes of short implants, and that is where it really matters because every millimeter is proportionally much more. So with this, I have my take-home messages to finish up. Peri-implant diseases are opportunistic infections and are not subject to overload. Has nothing to do. That is already stated by Professor Zitzmann. Risk assessment on the patient level therefore implies biofilm control on the patient, the therapist, and the prosthetic level. Systemic and environmental factors significant but have a low relative risk compared to the biofilm. The highest risk factor is the presence of an undisturbed biofilm. The IDRA evaluation tool is a reliable predictor for the peri-implant disease. And with this, I thank you for your attention with some greetings from a colder country.
That was a really important presentation. So much information there. Thank you so much, Klaus, for that wonderful lecture. Now we move ahead and we're looking to the future.
A glimpse of hope, perhaps.
Yes. Let's introduce our next speaker and see what it brings.
Let's do it.
Leading research on tissue regeneration.